I'd like to introduce Harry Petrushkin, who is a consultant ophthalmologist at Moorfields Eye Hospital, Great Ormond Street, and he does his private practice at Clinica London. He will tell you a little bit about himself, I'm sure, at the beginning, but he's here to give a lecture on uveitis. And over to you.
Yeah.
Thank you.
No, don't. Thank you very much for inviting me, and I'm very grateful for everybody giving up their evening to come and listen to talk about uveitis. I think when I started training, you couldn't pay people, so go and listen to somebody talk about uveitis. So it's really changed, and over the last 15, 20 years, the whole field I think is unrecognizable, from being something that nobody wanted to touch and there were no drugs for, to being something that there are now active randomized controlled trials going on. Drug companies are making us new therapeutics all the time, and it's really exciting. So it feels a bit like, I guess, rheumatology and nephrology felt in the 80s and 90s, where people started doing transplants and making transplant medicines, and actually the whole field moved forwards hugely, and we became much less reliant on systemic and topical corticosteroids. I'm going to try and keep this relevant to everybody in the room. I know all of you will have different levels of expertise. And if I say anything that you don't get, just put your hand up and stop me and get me to clarify, please. I want it to be quite informal. So the things, it's probably too small for the back, I should have tested this. So the things I'd like to cover are to identify different features that are associated with uveitis, identify different types of uveitis, to talk about referral locations and urgencies. So when you see somebody in practice and they've got uveitis, where should you send them and how far should you send them? And I'll go over that over quite a lot, talking about urgency and location as to what you should do. Determine what treatment you can give and whether it's appropriate to send them on to primary care, or whether they need to go to A&E, or whether you can refer them straight to a named consultant. Understand the role of shared care, which I think is becoming more and more common. Particularly during the pandemic, we started writing to yourselves more and more often saying, this patient's on topical steroids, they've had ocular hypertension in the past, could you see them and check their pressure? And just understanding where that relationship is and how it can really help patients, and knowing how to get help. So this, I think, is my main takeaway message, and I think people don't believe me. I think it's pretty common for colleagues to see cells in the anterior chamber, freak out and put them on tons of steroids and send the uveitis clinic and think that that's the most urgent thing about the patient. And actually, it's not. If a patient's much more likely to lose vision from a variety of other ophthalmic things than having some cells in the anterior chamber. So it's about trying to understand, if they have inflammation, then what? And I think if you think it through, and that's the kind of format I'll try and take, you can then either rest assured or panic and send them to the right place. So I'll cover things you'll commonly see, things you should be worried about, first-line investigations, and how you can get your patients seen. And this feels basic, but actually I think is not basic, because it's quite poorly defined. So uveitis just means inflammation, itis of your uvea, which is basically the whole of the inside of the eye. Your retina is not really your uvea, but we kind of treat it like it is. So for the sake of clinical practice, we'll call the retina part of it. And you can divide it into different locations, can't you? So you can say, well, it's anterior uveitis if it's in front of the ciliary body, it's intermediate uveitis if it's in the middle, and posterior if it's at the back. And I think that has some utility, but actually is quite a rubbish classification system. It's fine for trials. It's fine for just having something to get started with. But if you're trying to think about the severity of the disease, or if you're trying to think about what's actually going to happen to your patient, I would say that chronic anterior uveitis of childhood is about the worst uveitis you could have. That is devastating. You end up with a hypotenuse eye when you're 20. And actually lots of patients with posterior uveitis, which I think, again, raises people's blood pressure more, it's kind of fine. So, sorry, just this point. So the anatomical location is defined as where the bulk of the inflammation is, not where the inflammation is. So if you see a set of diagnoses that say this person's got intermediate and anterior uveitis, or posterior and anterior uveitis. That's kind of a nonsense because your eyes are snow globe, like the cells get everywhere. So you're talking about where the bulk of the inflammation is. So where is most of the disease? And actually, that's really easy for me in clinic to say once you've seen them and maybe given some treatment, or they've seen an A&E and they've been given some treatment. But when the eye's really hot, actually loads of them are pan-uveitis. Loads of them, just the whole thing is full of cells. Maybe they've got some macular edema, and you can't really tell. And I think pan-uveitis is not really a diagnosis. It's kind of a phase of their uveitis when they're really bad and they've ended up getting help. You don't see people chronically with pan-uveitis. Usually it settles into one of the bits of the eye. So you can subdivide it into whether it's infectious or not. And again, that is nice and conceptual and makes lots of sense. But we're really limited in terms of the infections that we can put our finger on and say we're 100% certain that this is the problem. So tuberculosis, great example. So we see about 150 cases, new cases a year of ocular TB at Moorfields, and about 20 at Great Ormond Street in kids. But it's almost all presumptive. So if you said to me, are you sure that this is tuberculosis in the eye? I would say, no, I'm not sure. It has an ocular phenotype, which seems quite a lot like tuberculosis. And they've got an epidemiological history of being exposed, or they've had a family member who's recently had tuberculosis. But we're never very sure. Syphilis is on the rise. We get more and more syphilis every year. And actually, that I think is one that you don't want to miss because it's completely curable. Like it's one of the few, it sounds awful to say, oh, you've got syphilis in your eye, but actually it's amazing because you can treat it and cure it and they're fine. It's monophasic, it's done, it's not coming back. And if you get it early and you treat it properly, people go from count fingers vision with a central plaque to back to 6/6. Borrelia and Bartonella, so Lyme disease and cat scratch disease, I have a bit of a problem with as diagnoses because the tests are rubbish. And unless someone's got a really clear, I was bitten by a tick, here's a photo of my tick, or I was scratched by the cat, and now I've got a macular star, and I've got disc swelling. Unless there's a really clear history, I'm quite skeptical because the laboratory tests are really bad. You may as well flip a coin. So we're really reliant on patients telling us what's happened to them and do they meet really classic ocular phenotypes. Behçet's, sarcoid, and multiple sclerosis are obviously all autoimmune or autoinflammatory conditions. And again, there isn't a test for any of those things. So there isn't a blood test that you can say, yes, you've got Behçet's or yes, you've got MS. They're all a constellation of syndromes. And so you could see somebody in clinic and they might have had an optic neuropathy, or maybe they've got a retinal vasculitis, and maybe you might interrogate them a bit further and say, yes, I've got pins and needles. But that doesn't mean they've got MS. They have to meet certain criteria. So the history taking is most of the diagnosis really in uveitis, because unless you have, say, syphilis, actually the rest of it's really, you're putting together these pieces of the puzzle. And I'd say 70 to 80% of our cases, we don't get a proper, in quotation marks, diagnosis. And that's just a limitation of where we are in medicine. It's not to say that we won't have an underlying cause in the future. So when you see a patient with uveitis, when you see cells in the front of the eye, ideally you would be quantifying it. And at the moment, we're still using the SUN criteria. So that's the standardization of uveitis nomenclature. So that was designed about 20, 25 years ago, really for clinical trials. And you score them by looking in a 1 millimeter beam, how many dots floating around the anterior chamber can you see, and you count them. And I think that that's hard. I find that hard, and it's my job. I do it all day long. If they've got half a plus of cells and you can count somewhere, you can count 0 to 6, that's fine. 1 plus, maybe you can count 15, but any more than that, you're slightly guessing, I think. And within 5 years, I would say we will be entirely reliant on anterior segment OCT to do that for us. And we'll have validated the algorithms, and anterior segment OCT will be telling us what the anterior chamber cell count is, which will be better and appropriate. The one thing that it can't do at the moment is measure flare. And again, flare is wildly subjective. So if you look it up and you're actually saying, well, how do I really score flare? It's all about how clearly you can see the iris. And 4+ flare is, that the eye is full of fibrin. And 3+ is, I can see it just about. And 2+ is, I can see it, but it's hazy. And 1+ is, I can see it, but there's something there. It's a very subjective scoring mechanism. So the flare meter stopped being manufactured. So we can't really objectively quantify flare anymore. And so we rely more and more on what the cells are doing and your clinical description of what the anterior chamber looks like. So how can it lead to visual loss? So I want to keep coming back to this. So if you've got a patient in practice that you see, how is their uveitis going to make them lose vision, if at all? So we know that 10% of patients who are registered as visually impaired have uveitis, and they're young and they're working age, so you don't want to miss it. You know that these are patients who are very vulnerable and have a lot to lose. You kind of always know that loss of vision is going to be from macular edema, visually significant vitritis, which hardly ever happens, and cataract. And you can cure macular edema 99.999% of the time. You can cure cataract basically 100% of the time. And the vitritis is rare, and if it's there, we can cure it. So it makes you wonder what we're also panicking about. The cells in the anterior chamber are not going to blind anyone. The cornea, if they get keratic precipitates, you can get rid of those. If they decompensate their cornea, then that's a multidisciplinary meeting between us and the corneal team, but there are solutions for almost everything. So it's quite rosy, really. So when I see patients, I don't go, oh my God, they've got uveitis. I go, oh, great, how are we going to fix this problem? And there usually is a fix. The secondary glaucoma, I think, is unacceptable. I think whenever we cause secondary glaucoma from steroid-induced ocular hypertension, that leads to glaucoma. That's iatrogenic morbidity that we should be reflecting on regularly and saying, how could we have avoided that iatrogenic disease? Because we cause that. A patient comes in with 1+ cells and is asymptomatic. You get rid of that and you give them glaucoma. That's not, you haven't done a good thing there. And so I think just weighing that up. Hypotony historically has always been the death knell of eyes. We've been working for the last 4 years on hypotony treatment programs at Moorfields, which have worked really well, actually. So we have lots of patients who have gained 8 lines, who have sort of been hypotenuse and 160 for quite a long time. So that's really exciting. And hopefully will be coming out later this year. So what do? We can give them steroid drops, we can give them non-steroidal drops. I'm somewhat skeptical, although I acknowledge that they do have a role, non-steroidal eye drops, but I don't think that there is much of a role of you seeing a patient with uveitis and starting them on some macularis and Nevanac before they can see somebody else to start them on some steroids. I don't really think that that's not really a treatment pathway. We can give them steroid tablets and steroid-sparing agents. And we've got loads of other drugs. We can give steroids either intravenously or intramuscularly or subcutaneously, or we can give steroid-sparing agents and biologics. And I'm not going to go into the hardcore drugs we use too much, because I think it's useful if you know what they are. It's probably not a great use of your time for me to drone on about it for 20 minutes. But the general principle is that when we see somebody who's really inflamed, we hit them really hard with oral or topical or intravitreal steroids, and we immediately start them on a second-line agent. And we're able to do that because we know what the natural history of most of the diseases are. So if you can see a patient and you say, do you know what, whatever happens here, this person's going to have disease for the rest of their life. And I could give them a steroid taper, so I could start them on a massive dose of oral steroids, and I know they'd get better. And then I know when they hit 10 milligrams of steroids, they'll get worse again. And I know that someone else is then going to put them back up to 60 milligrams. And I know they're then going to get diabetes and have Cushing's disease and all of the other steroid morbidity. When you sort of know that that's likely to be what's going to happen to the individual, you can skip to the end and say, what you need is control today and a long-term management plan today. And so that is what we do more and more now. So I would see a patient on my first visit, I would say, here's your steroids, here's an information sheet on mycophenolate, on methotrexate, take it away, read it, we're going to see you in a few weeks, and we'd be aiming to start it then. I do all the baseline screening when they come in, and then we would get them started on their second-line treatment as soon as possible. And that's because those second-line treatments take ages. Methotrexate takes 6 months to work properly in the eye. So that's a long time. And if you're going to have to control the disease with steroids in that interim, you want that interim to be as small as possible. I really like this as a framework thinking about disease. So this is brought to me by Professor Narcis Okravi, who was one of the uveitis consultants at Moorfields as head of education. And I just think it's really memorable and really easy. And so you think, what's the pace of the disease? Is it a fast disease or a slow disease? So for example, birdshot chorioretinopathy, slow disease. You'll lose vision over decades. JIA uveitis, slow disease, bad, but slow. So whereas a viral retinitis, fast disease, you need to do something today. What's the threat? So with, let's say, JIA uveitis, the threat is long-term hypotony, loss of structures of the eye, burnout of ciliary processes. That is why the whole thing goes wrong, because you have a disease that primarily targets your ciliary body. Whereas the threat in birdshot, for example, would be that your choroid is inflamed and it rots your outer retina, and you're going to lose your retina first. And so I think knowing what the threat is, what the pace of the disease is, really helps you target what treatments you're going to give them. And it also helps you triage your referrals, because if you see somebody who's got asymptomatic anterior uveitis in clinic, for example, or on the high street, then that's not a burning platform. It needs dealing with. You need somebody to look at them and phenotype them properly, but nothing awful is going to happen. Similarly, if they have 100 microns of macular edema, that looks really scary when you do an OCT and you see macular edema, but nothing awful is going to happen. If you can see the impending central retinal vein occlusion, which is about to turn into an ischemic central retinal vein occlusion, that's a completely different story. So it's just putting the framework around what you're seeing and not reacting just to the clinical sign. And this bit, which is a bit more prosaic, but actually is really important. So if you've got a patient who is already on lots of immunosuppression, or already having dialysis or from their diabetes, those are individuals who are immunosuppressed, someone who's had a bone marrow transplant. The whole thing, the pace and threat of the disease, the whole clinical phenotype looks completely different in somebody that's immunosuppressed, because it's an immune disease. The thing you see inside the eyes are immune cells, and if you haven't got any immune cells, the disease is going to look different and potentially present much later. So, things you might see. So you might see a recurrent anterior uveitis. I think that's common. Everybody in this room will have seen a patient with recurrent anterior uveitis. They come in with photophobia, they're uncomfortable. Almost nothing terrible is likely to happen to an eye that looks like this. So they've got no chorotic, they've got some chorotic precipitates, they've got no synechia. So if you think that the worst thing about this eye is that it hurts, and that the patient is photophobic and they can't work, they might be able to not do their activities of daily living. Pain is that's the thing you have to deal with. So you can cycloplegic them and you can give them steroids. And there isn't a right regimen for steroids. You'll all work in different places, and you will have seen different regimes where someone starts an hourly, some people start on 4 times a day, some people give Predfort, some people give Maxidex. There is no right answer. So everywhere has their own protocol, and usually that protocol is designed, if you're in a busy unit, to prevent as many people as possible coming back because they're not quite under control enough. So, the heavier you hit them, the fewer bounce backs you'll have, which makes sense from a just managing your service perspective. But what you will see from time to time is young people coming in saying, I've had 100 episodes of uveitis. I know what it is. I know how to manage it. And you may look at them and see, there's one cell, there's half a plus of cells. And that's a really common story, that professional patients who really know their disease will come in to A&E and say, I'm having a flare of uveitis. And they'll see a junior trainee who will say, no, you're not. You've got some blepharitis or some dry eye. Go away with some lubricants. and they'll come back the next day or 2 days later with awful uveitis. And so I would always trust the patients. I mean, I can't think of the last time that a patient wasn't right about them having a flare. And they get really sensitive to the prodrome as to what it feels like before it flares up. So I think one of my take homes would really be about believing patients when they say that they're having a flare up, because they are usually right. And actually, just as a side point to that, I think historically we were really cautious about represcribing without seeing the eye because of the risk of it being a dendrite or something. I'm really not that worried about that. And throughout COVID and subsequently, we've had patient-initiated follow-ups for recurrent anterior uveitis where patients have bottles at home. They treat themselves at home. They call us when they flare up. They come in, we check their pressure. It works really nicely. And if you're young and you don't want to spend hours waiting for drops that you know you need and have to explain your disease to somebody that's potentially never seen it, it's a real game changer. So you can have granulomatous or non-granulomatous anterior uveitis. Granulomatous is a silly word that people made up a long time ago in ophthalmology we sort of took a histopathological word, which means I've seen granulomas on a slide when I've sliced something up and looked at it under a microscope, and applied it to eye things that happen in granulomatous diseases. So granulomatous chorotic precipitates aren't really granulomas, they're just aggregates of white blood cells. But it's a word that has kind of been grandfathered into our vocabulary. So it's not a great term, but it's also here to stay. And so you can get it on the iris, you can get it in the angle. And it tells you a lot about the disease. So granulomatous disease is likely to be sarcoid, it's likely to be tuberculosis, it's almost never going to be Behçet's disease. And so you can tell a lot by looking at the cells and looking at the chorotic precipitates. Everybody will have seen patients with Irvine gas syndrome. I think I always I'm an hour about whether to put it in a uveitis talk, but I think it sits best here because it doesn't really sit anywhere else. And patients with ongoing macular edema get referred to us for management. So you do get this shape in other types of inflammatory macular edema, but it's really rare. It's a really perfect volcano. You almost never get much inflammation elsewhere. They never really have vitritis. Maybe they've got some anterior chamber cells. They've usually had cataract surgery. If they haven't had cataract surgery, it's not Irvine gas syndrome. And so you need to think again. If you get a person that just walks in with macular edema and no cells and nothing else going on, that's weird and actually needs referral because sometimes they have odd other things. So sometimes patients have lymphoproliferative disease that ends up being just macular edema and nothing else at all. So that would be a red flag for me if you've got macular edema and you're phakic and you've had nothing ever happen to you and you've not had a vein occlusion and you've not got diabetes and you've not had any of the other things that it's likely to be. And this often settles just with another course of steroid. And sometimes we need to keep people on steroids. We would usually manage them with topical and non-steroidal, topical steroids and non-steroidal drops, and then taper off both over a course of 3-4 months. I think intermediate uveitis is interesting because it, again, really gets people concerned, particularly if they see a snowball. A snowball is a historic event. So if you see these things down the bottom of the eye, it doesn't mean they don't need investigation. But what you're looking at is historical. You know, when you look up at the night sky, it's something that happened millions of years ago. This is something that happened a long time ago. It's happened for a reason, but it doesn't necessarily mean the reason's still there. Your eye's a snow globe. It's got nowhere to send its rubbish other than in the middle of it. So it just sits there and it's at the bottom, basically because of gravity. So there's really only one way that you can get lymphocyte aggregates sitting at the bottom of your eye and your vitreous, and that's they have to come out of your vessels. There really isn't another way. And all uveitis is at some level of vasculitis because it involves white blood cells getting out of your circulation and into your eye. There aren't supposed to be floating white blood cells in your eye, so to get there, they've had to come out of a blood vessel. And for them to get out of a blood vessel, either someone's thumped you or you've got inflammation of your blood vessel, which means it's leaky. So sometimes you see intermediate uveitis. You look down at the bottom, you see those snowballs. It's historical. If you've got a patient with new visual loss and tons of rubbish in their vitreous, obviously they need investigation. But again, you can think about what's the pace of the disease? What's the threat? Having vitritis means they can't see, but if you can see the retina, you know nothing else is going on. If you can't see the retina, that's urgent because they could have an acute retinal necrosis, they could have a big toxo scar that needs treating. But if you can see the retina and everything's fine, then you do have time and you could make those named referrals or you could send to a specific place. If you can't see the back of the eye and they've suddenly turned up with a whiteout and a vitreous, then they probably need to go to A&E. These kind of veils are quite pathognomic of lymphoproliferative disease, so things like intraocular lymphoma you would worry about, particularly in older patients. It's quite obvious. It's one of those things where you think, well, I'm not sure I'd see that. But if you dilate them and you've got your slit lamp beam at an angle and you see these kind of sheets of cells, it's quite obvious. And again, if you're not, the pace of lymphoma is slow. And again, you would worry about missing cancer, we all would. But even if it's an intraocular lymphoma, that's not a same-day diagnosis. You could send that to the right place. So just thinking about what's going to happen. So again, with the same framework, this is also a patient with recurrent anterior uveitis, but it's different to the first one I showed you. And it's different because of the synechiae. Because this patient's at risk of going into iris bombay and their pressure suddenly shooting up to 60 and losing vision. And so that's a completely different scenario. So whereas the first patient, I'd say the main issue there is pain and inconvenience. Here, I would say the main issue is trying to break as many of the synechiae as possible. And if you can't, potentially doing an iridectomy or an iridotomy to try and give you a secondary outflow to stop the patient from going into iris bombay. Laser iridotomies in these sorts of eyes don't really work. I mean, you might just about be able to make a hole in a blue iris that will last for a bit. But in a brown iris like this, you'll just be hammering away for ages. The eye will fill up with blood. It won't work. So you need to take them to theatre and do a surgical iridectomy, which is easy and easy to organise and quite a relatively easy procedure to do without many complications, but is something that needs to happen. But again, not on that day, soon. This is the eye of a patient who was sent to me last year. So clearly, she's got a white cataract and has completely zipped up. Her pressure is 0. So you might think that the pressure in this eye would be 500, but it's 0 because it's a chronic anterior uveitis. Patient had JIA. The ciliary body basically non-existent when we did a UBM. And so you have to think quite carefully about an eye like this, because this woman's in her 20s. She may be completely amblyopic. You may take that out and open Pandora's box. And so I think that counseling piece is really important. And again, something like this is very, I mean, it's not routine, but it's routine in terms of referral. You need to make sure that this gets to the right person, because the worst case scenario is somebody going, I'll have a go at that, and making the whole thing much worse. I think if you've convinced yourself that you've seen white dots in the retina, you should assume that it's a viral retinitis. Unless there's some other reason for the patient to have white dots in the retina, the thing that will cover all of you is just to assume it's a viral retinitis and send them straight to the local emergency clinic, because those eyes need intravitreal antivirals, which most people don't carry. And they need to be started on oral antivirals, and they need to have all the right treatment, and they need to have an anterior chamber tap and everything else. So this actually, I'll talk through this case because he's interesting. So this is a chap who came to Moorfields A&E many years ago now, and was seen without the benefit of this photograph. So someone just looked at him through a slit lamp, and they saw this, and I think they saw this, and they thought it was toxo. So that's not ridiculous. They've got a pigmented scar. You get pigmented scars in toxoplasmosis. He's got a pigmented scar. He's got a white fluffy thing. You get white fluffy things in toxoplasmosis. Not ridiculous. The vitritis isn't very bad, but sometimes you don't get your vitritis isn't that bad in toxo, but usually it is for a reactivation. The thing that doesn't really work is that this should be touching this or right next to it. So a classic reactivation of toxoplasma chorioretinitis would be a white fluffy thing on the edge of an old black thing. These white dots everywhere. That's what makes this a viral retinitis. Anyway, so he was given in A&E steroids and antibiotics for toxo, which was fine if it was toxo, but it wasn't toxo, and then brought back in a week. And the problem here is that you've given a patient with viral retinitis unopposed steroids. So that's really bad. And that's why you should always assume it's viral. Because let's say you take a toxo patient and you treat them as a viral retinitis, it's not the end of the world. Toxoplasmosis is a self-limiting condition. You know, it's not the end of the world. Whereas this actually is, this is bad because you've made the whole thing worse by giving them unopposed steroid. Well, this is, so we don't know. And this is also what happens anyway. And this is, I want to come back to that. That's a really good point. So had you picked it up on day one, maybe this wouldn't have all happened. Maybe. But I actually think with the viral retinitis, when you see it, there's tons more damage that you just haven't seen yet because the damage hasn't manifested. So you'll see what goes on. So this person still got 6/6 vision and normal pressure. And we did their workup. This is basically negative. So they haven't really been exposed to toxo. So do you all know, out of interest, I don't know if this is of interest to you, so IgG and IgM, is that like a thing that's on anybody's radar? So those are antibody levels. And they're different types of antibodies. So you get IgM when you've recently been exposed to a bug. So if you get COVID, you get COVID IgM. And then we've all been vaccinated, so now we all have COVID IgG, which is your long-term memory. So if you test patients for toxoplasmosis, if they've been exposed in the past, you'd expect that IgG to be positive. And me? No? Okay. I thought I'd done something. And you'd expect their IgM to be negative because it's old. So that's what that means. This basically means toxo shouldn't really be in your differential. So 10 weeks later, he's got better, he's got worse, he's got better, he's got worse, he's got better. He's 6/6. And then at week 20, he detaches. And again, that's really classic with the viral retinitis. So something like 70 or 80% of our patients with acute retinal necrosis detach. And so you may see patients in the community, if they can't get to us, they may have said, oh, I've had all these injections in my eye from this virus, and then I was fine, and now suddenly I've lost vision. And I think just understanding that actually this is almost a natural history, I would say, of a viral retinitis, because the whole retina is perforated by the virus. The retina is really, really sick. And there have been millions of different trials over the years trying to treat the retina with laser to stop patients from detaching. Nothing really works. So we are left with this, you worked really hard for 10 weeks, you've got the vision back, and then the retina falls off. And it's really heartbreaking. So first line investigations and treatment. I think this is absolutely where your role in patient care is huge, because you get the baseline images and we never get the baseline images. And sometimes you see pathology and you've got no idea. And occasionally a patient will come along at their next visit with 10 years of optom photos. That's amazing. It completely transforms their management, because if you see somebody who, I don't know, has had intraretinal fluid and you have no idea how long it's been there, or they've got a scar in their macula and you've got no idea whether that was 100 years ago or 1 year ago or 6 months ago, and they've got their serial photos that you've all done, it's a totally different conversation. Because one thing is something that happened really long ago and your treatment might cause morbidity and it might be completely unnecessary. And another thing is evidence that this is a recent condition and should be treated. So I can't wax lyrical enough about when patients come in with recurrent baseline imaging, even if it's just a top-con posterior pole, but the more the merrier. This whole, is there any amblyopia thing, is something that for me comes up over and over again when patients have got poor vision. They turn up with poor vision, you have no idea what you're trying to get them back to. Knowing what you're trying to get a patient back to is key. And if they've never seen anybody, or they've perhaps never got their glasses or haven't been checked for a decade or two, then you just don't really know where you are. So documenting whether there's any amblyopia and patients understanding that that eye's a lazy eye and didn't see very well. But even in that scenario, even when there is amblyopia, knowing what not very good is, because actually often the amblyopic eye becomes the only eye. In my world, that's quite common. And so an amblyopic eye that's 6'9" is, great. I'm happy to try and get you back to 6'9", but even if your amblyopic eye was 6'36" and you're now hand movements, I'd be delighted to get you back to 6'36". The transferring of images via secure platforms has really come on, right? And I think a lot of you probably will have seen or been part of pilots where you can send images directly into hospitalized services to get patients triaged. That's only going to get better. We're all now plugging into ERS. Single point of access is going to make that easier and easier. So I think patients that you're really concerned about, or patients that you're not sure how concerned you should be, that's the perfect medium for that, because you can just ping those images straight through, people can review them, and then either say, yeah, it's fine, refer as normal, or, yep, you're completely right, that person needs to come straight into A&E. A good medical history is key, but I think if you're stuck between getting good imaging and taking good history, I think actually that getting clear imaging that you can transfer over is really important, because really we should be taking a clear medical history as well. So if you're not sure, if the patient's got some cells and they've got some surface disease and they've got some blepharitis, it saves everybody, it saves the patient time, it really helps us if all of the ocular surface stuff is dealt with. And you can deal with that just like exactly as well as we can. So if you're not sure whether something may be ocular surface, please get the blepharitis dealt with, please get the ocular surface dealt with, because actually sometimes that just magically cures everything. Patients do with really dry eye sometimes get cells. And if it's not going to cure the problem, at least it's been dealt with so we can then move on to the next step. If you think you've got somebody with, say, scleritis, and they walk in with a really classic history and they say, oh, I can't sleep at night, pain wakes me up from sleeping, it's 10 out of 10 pain, it's a dull, deep, boring pain in the back of my head, or sorry, in front, in my temple here. You can advise those patients to take ibuprofen if it's safe for them to take it. That's fine. And I would welcome that, because then when they see us, they can give us a response to therapy. And that is what we would usually do in the first instance anyway. This is what I was talking about, some patients having a self-management plan for anterior uveitis. So they may come to you and say, oh, I've been seen at Moorfields, I'm on a PIFU, patient-initiated follow-up plan. They asked me to come and get my pressure checked because I've been taking topical steroids. So that may be something that you start to see more and more. And again, if people come in with cracking eye pain and they're vomiting, that's likely to be raised pressure. I saw a patient, in fact, today that we did an anterior chamber tap on for a viral anterior uveitis. He bled, and their first protocol was their optometrist, and they had the front of the eye was full of blood and their pressure was 60. So I think just having a sense as to what's happened and what the natural history is and where to send them is key. So what's your pathway? So if you're local to us, we would love to see them at Clinica, but it has to be appropriate, right? You don't want to be sitting on a viral retinitis patient and saying, oh, I can get them into Mr. Petrushkin's clinic in 2 weeks on a Monday. That's 100% wrong. You should send that person straight to A&E. Whereas if you've got somebody who's got a problem that's relatively stable, then obviously we see them in Clinica and work them up appropriately. Knowing where your local emergency clinics is key, working out what your GP colleagues can do. I think realistically, GPs do less and less for eyes, and you guys do more and more, and I think that's completely appropriate. And often GPs will, in fact, almost all the time, GPs will be deferring to you. Moorfields is 24 hours, always welcome to come in. And whether you do a named private referral or your local A&E, I think depends on the problem. I would say that local general A&E departments are often not a great place to send eye patients. It depends where you are. It depends how mobile the patient is. But often, if the patient has the ability to get somewhere with 24-hour ophthalmic care, like more feels like the Western's not 24 hours anymore, but they will, the time they spend getting there, they will get back in the time they spend waiting for an eye doctor to come and see them who knows what they're talking about. Or they'll see an ST1 who doesn't really know and then needs to call their registrar. Like, you end up with a lot of waiting in general hospitals. And it depends on the hospital, it depends on the setup. I'm generalizing massively. But just think a little bit about whether that's what's in the patient's best interest and what's appropriate for them. So I thought I'd finish with a case that I saw quite a few years ago now, but I remember him very clearly because it was the start of my consultant job. He was 12, and he'd had a history of a T-cell leukemia in 2013. He'd previously had medication to treat his T-cell leukemia and not had a bone marrow transplant. So this is 5 years later. His vision's 6.965, pressure's okay, both eyes have got 1+ of cells and a bit of vitritis. And this is what the optometrist sees. And so I think quite scary if you're not expecting this in a 12-year-old boy. And I think he's quite a good case to talk through to test that framework, because when you look at it, initially it's scary. But then if you slow down and look at it and think, well, what is active and what's old? You would start to see that actually almost all of this looks old. Black stuff is always old in the eye. And if you've got white stuff in the middle of black stuff, it's probably old as well. What you worry about is white stuff that's there. You know, white stuff here is no good. White stuff around here, it's probably old. So actually, basically it's all old, isn't it? You know, if you look all the way around, you've got this dragging from the disc. That's clearly a feature of chronicity. And his OCT looked like this. So again, I was saying that, you know, if you've got 100 microns of macular edema, that's not a urgent disaster in the middle of the night referral. This guy doesn't really have any, well, he has a little bit of intraretinal fluid and he's got some subretinal fluid, but most of it's tractional because he's got an epiretinal membrane. So he was diagnosed with bilateral intermediate uveitis with some macular edema in the left eye, a diagnosis of previous CMV retinitis. And so if you look at this picture again, that is a classic old CMV retinitis, cytomegalovirus retinitis, which would have happened to him 5 years ago when he was having his chemotherapy for his leukemia. He would have been really immunosuppressed. CMV is a bug we all carry, and because he was really immunosuppressed, the bug went to his eye and affected his peripheral retina, and he didn't notice, because kids don't notice anything unless it's really awful. And nobody would have looked in his eyes, because why would you? And he would have got better, and he did get better, and he's in remission from his leukemia. And what happened as he reconstituted his immune system is he developed something called an immune recovery uveitis, which these days is relatively rare. It was really common in the HIV pandemic, actually, when we saw loads of people with CMV retinitis. But these days is much rarer, and most of the CMV retinitis we see now is due to patients who are immunosuppressed from bone marrow transplants or from cancers. So he was interesting because we started him on valganciclovir, which is an anti-CMV drug, really to make us feel better in clinic, because we knew that CMV was involved, but until we felt fully reassured, we just wanted to put him on therapy, which I think was appropriate, and treated with topical maxillosis macular. But actually he started to get worse. And it's interesting because this is a really long time after the insults. And it's taken him that amount of time for his immune system to start to reconstitute. And what he's effectively doing is having an autoimmune response against his own retina, because when he had the CMV retinitis, it opened up the retina to your immune system. And so when you open up your retina to your immune system, it's stuff you've never seen before. The way your body learns not to attack your brain or your eyes or your ovaries or testes or joints is through a process of immune education when you're a baby. So you literally show in your thymus gland, you show your immune system all of the different bits of your body. And then it says, yeah, that's fine, that's me, that's me, that's me. I'm not going to worry about that. And that process of education happens when you're a baby. So when you're an adult, you can't really learn something is or isn't you. So if it's new, it's not you. And that's what generates most autoimmune disease. And so that's really what we're seeing here. This is a person's immune response reacting against retinal antigens. His vision's still all right. We're not surprised that his IgG is positive, because as we said, he was exposed before 5 years ago. He had disease 5 years ago. And so I said, that was his diagnosis. And he's actually done very well with intravitreal steroids, which you might be concerned about in somebody in the context of viral retinitis. But because he's healthy now and has a totally normally functioning immune system, the way that we managed him for a long time, 8 years, is just with intravitreal steroids, because that's the only thing that's worked. And he's still 6'9" in both eyes, pseudophakic, never had a pressure response, and is doing well. So I guess my learning points are that you guys are essential in providing world-class care. I really think that moving forwards, that shared care between hospitalized services and the community is what best care looks like. Patients don't want to come and see us every 5 minutes. They'd much rather come and see you every 5 minutes and see me sometimes. Uveitis, not that hard, and basically not that scary either. Remember this toxoplasma acute retinal necrosis thing, because I think that that is something that may come up from occasionally in your practice, and just to always treat and refer urgently as a viral retinitis if you're not sure. And remember this whole concept of anterior uveitis more and more being managed by the patient with our support, rather than them needing permission to treat themselves when they know what's wrong with them. And that's it. Thank you very much.
I'm sure you can take some questions. And we're going to be using the little microphone if you would like to ask questions. Yes, here you go. Face towards you. Thank you.
So we do get quite a few cases of toxoplasmosis. I generally don't panic about it till today when I heard that. What sort of things should we look out for to differentiate between, and whether we should refer them or not? And on how urgent would you like us to refer?
Yeah, that's a really good question. So the things I would worry about with toxoplasmosis is if they've had a reactivate, if they've got an old scar, I don't want to see those patients. If they've got new visual symptoms, I almost always want to see those patients. And so if they've got something affecting their macula, a new white fluffy thing affecting their macula, they need full toxotherapy. So that's a really big dose of steroids and antibiotics. If they've got something a million miles away, out in the periphery, and they're still 6'6", they've just got a few floaters, you can leave those patients alone. They're fine. But if they've got something out in the periphery and their vision's dropped to 6'12" or 6'18", I would give those patients steroids. And I would also, the OCT will be fine because the thing's out in the middle of nowhere. So that's giving them vitritis, hosing out immune cells from that area. They will self-resolve. And so I think that that's a conversation, but it's a conversation that needs to be, it's a shared care conversation, right? So it's between us and the patient. We would say, we can give you loads of steroids and some antibiotics, or we can leave you alone. If we treat you, you'll get better fast, but you'll have to take all these drugs, or we can leave you alone and you'll get better slowly and probably have more floaters at the end of it. So I would say if someone's vision's dropped, or if there's anything affecting the back of the eye, the posterior pole, discs, vessels, we would want to see those patients.
The main thing is the VA.
Yeah, I actually, so the question again, it's okay, I'll repeat the question. So the question was, if the OCT is normal, is that a feature? And so I actually think that the OCT is irrelevant in this scenario, because it doesn't really tell you anything you don't know from the color fundus image or from your examination. What you're looking for is the lesion fluffy and new? And is it affecting the vision? That's almost all. Does that make sense?
Yeah.
Because actually, if you do an OCT through it, you'll see that you'll have full thickness retinal lesion, you'll have choroidal thickening. So what? It doesn't change what you do. If it's pigmented, it's old, and if they've got no symptoms, then you can sit on them and watch them.
What's the best way to distinguish between a cotton wool spot and vivo-retinitis?
Oh, that's a really good question. I think the patient, like what's going on with the patient, I actually think it's really hard. I find cotton wool spots quite hard. And I think when you examine them, when you examine patients with cotton wool spots, and you're not expecting to see them, fine. If their blood pressure's 200/100 and they're eclamptic and they're about to give birth, then you'd expect to see some cotton wool spots. But if they haven't got a reason to have cotton wool spots and you see them, I think that's a tough call, and I probably wouldn't, I personally wouldn't want to be the person making that call. So if you see somebody, if I met somebody in the community and I saw a load of white fluffy things in their retina, I would treat that as viral retinitis and let someone else write back and say, I can't believe you didn't think that that was cotton wool spot. I would, I don't think, correct me if I'm wrong, in the position to be checking patients' blood pressures. No. So you're not in that patient may be really hypertensive and actually have a pheochromocytoma, like it's a tumor of their adrenals, putting their blood pressure up. Maybe that's why they've got cotton wool spots. Maybe they've got awful lupus retinitis, and those are all things that need urgent attention. So they need to see the right medical team to do that. So I would distill it down to new white fluffy thing you can't explain. Yes, it might be a cotton wool spot, but if you can't explain it, unless they've walked in saying, oh yeah, my blood pressure's out of control, I've had those white fluffy things for ages, or probably that's about it. I would send them urgently. The other thing it could be is a Behçet's infiltrate. So patients with Behçet's disease get retinal infiltrates, which again, I think it's unreasonable to expect you to know the difference clinically between. I probably wouldn't want to guess 100% of the time, and it's all about the rest of the stuff that's going on with it.
Any other questions?
I have a question. So you mentioned earlier about secondary glaucoma and how those are the cases which you have to sort of take a look at, did we cause that?
Yeah.
But in the vast majority of these cases, we have to give the steroid. So what is your thought process when you've caused it, or when that's happened in terms of, looking at analyzing what you could have done? Sometimes you might not have been able to have prevented
Well, so I
that.
think it's about tolerating, isn't it?
Yeah.
It's very easy for us to give all the steroids in the cupboard to clobber the patient's inflammation until there's none there.
Yeah.
But in somebody that's if it's a brand new patient, you don't know about it.
Yeah.
That's, you can learn not to do it again in the future. But if you've got somebody that's come in, you can look at their history over the last 10 years. They've had an episode of anterior uveitis, their pressure's gone up to 60. You've had to give them full medical therapy. The pressure's come down, they've come in again, their pressure's gone up to 60. You can predict that. That's no longer news. It's no longer a surprise. It becomes a point where you've neglected to proactively manage the pressure by, say, putting them on Diamox or something else when you give them the steroids, or electing not to give them as much steroids or a different steroid, or do glaucoma surgery in between attacks. There's a point where your brain can kick in and be like, hang on, am I just going to keep doing the same thing over and over again until we cut this person out, or are we going to do something a bit different?
So I guess it's only applicable in first-time patients where you don't know they're going to be steroid responders.
If they've never had it before,
yeah,
you don't know.
Yeah.
But the right thing to do is to see them not in a million years.
Yeah.
And check that their pressure's reasonably controlled in a couple of weeks.
So as long as you have checked them within a couple of weeks, you should be able to.
Yeah. And I think actually I say that, but I don't think that happens all the time.
Okay.
So I think if we see a person in A&E and we start them on hourly drops, that'll be a 6-week taper. Often we'll bring them back to clinic in 8 weeks. I think probably best care is an optom pressure check at week 2. I think that is really good care and not something we do very often. But if I had to design it again, I would say that probably is what I would like if it was me.
Okay. Thanks.
Because otherwise you miss it, right?
Harry, when patients get to see you, I don't think you rely just on looking at their retina and a few OCTs. I believe you do a gamut of blood tests as well. Tell us briefly a little bit about that.
So patient turns up with one episode of anterior uveitis. They get better, you see them, they never have another episode. I don't think you need to investigate those patients. They're fine. A patient turns up with one episode of anterior uveitis. Every morning, they're really stiff, they can't move. They can't, they get really bad back pain when standing still for too long. They have blood in their diarrhea and they've been losing weight. That person needs investigation, right? So they probably are HLA-B27 positive, and they'll have ankylosing spondylitis, which is really common. We're really bad at picking this up. As the whole ophthalmic community, all of us, are really bad about asking for associated symptoms in inflammatory back pain. We should be better at that. Those patients definitely need bloods. I would say anyone other than that initial patient who has recurrent episodes needs a full workup. And there are different reasons for having that. So you would check their full blood count, you check their liver function, their kidney function. Most of the time, that should be normal. Sometimes you pick up anemia, sometimes you pick up unexpected things. But if you're going to immunosuppress somebody, you need the baseline. Just like you're doing their baseline imaging, we need their baseline bloods. Everybody who comes anywhere near me gets an HIV test and a syphilis test, because again, the immunosuppression status of the patient colors everything. And I need a negative infectious screen. So everybody will get tuberculosis, HIV, syphilis, toxo if relevant. I don't do toxo on everybody. And then I would do an angiotensin converting enzyme, so serum ACE, to look for evidence of inflammation in their chest if they think they've got sarcoidosis. And that would usually be an inflammatory marker, if there's any inflammation in their body. So that would be my baseline workup for uveitis.
And when you're treating them, you said, you mentioned intravitreal injections of steroid. Do you have to do that very often?
Yes, I do. I do it very often. But I think, again, that's picking your risks. So let's make up a patient. You've got a 10-year-old patient who's got some macular edema and anterior uveitis and is 6'6" and has no normal pressure. Giving that patient an Osidex, so intravitreal steroids, will sooner or later, maybe you get away with one, but pretty soon after 2, definitely will give them a cataract. Cataract surgery in a 10-year-old is a big deal. Giving that patient steroid-induced glaucoma is a big deal. Children generally have quite a punchy response to intravitreal steroids. Now, let's say that the same patient is, a different patient, let's say a 77-year-old with chronic intermediate uveitis, who's already pseudophakic, who keeps getting macular edema after her cataract surgery. Intravitreal steroids is an amazing option for that person because they don't have to be putting in 6 eye drops a day. They're already pseudophakic. Yes, you may have a pressure problem that you need to manage, but most people don't. And if you do need to manage it, it's just with drops. And actually that individual may much prefer to have an intravitreal implant that they haven't got to worry about. So it's slightly horses for courses, and I think it's very much patient-based. Everything has risks, and it's about which risks are least bad for the patient.
Thank you. Are there any further questions?
Your ARN patients, if you're thinking it's viral, you AC tap all of them?
Yeah.
Okay. And your patients with possible ocular lymphoma, is it a good idea to refer to uveitis and Moorfields Oncology, or
Actually, to be honest, the best service in London is at King's.
yeah?
Yeah, so
I
Ed
don't know.
Pringle's.
Yeah, Ed does. He does a biopsy, usually a retinal biopsy, because for the lymphoma patients. But
Yeah, and they can do IL-6, IL-10 levels. So that's you take a sample of the vitreous and look at balance of interleukins inside the vitreous, and that gives you a sense as to whether it's more inflammatory or more likely to be a tumor. So King's is actually the only place that's got that out.
although I had a patient who came in referred from diabetic screening with a posterior sneaky because it wasn't dilating, and she had active uveitis, but she had this really weird iris fibrosed bit. And I treated the uveitis, but I referred her over to Moorfields. It turns out it was a granuloma because she had sarcoid. But
Yeah.
I don't know if people get annoyed if you refer stuff over to.
No, I think generally speaking, we have no business being annoyed by patients being referred anywhere. Like that, our whole job is to look after patients. So I don't think ego should not be a thing here.
One of you asked me earlier what it is about Clinica London that makes us stand out from other places. And I think listening to your talk, I now realise what it is. We see all the general things. So we will see the acute anterior uveitis. We'll see the retinal detachments, but we have at the same time a very fast route into some fantastic specialists, such as Harry. And we're really pleased to have you at Clinica London. I mean, already you've made some great diagnoses on some of the patients that have come along with a hot eye.
I do think one of the reasons I like working here actually is because everybody is excellent and everybody works in tertiary centres and there's a very collaborative. I think private practice can be thorny and sometimes you can end up with people who potentially aren't world experts in what you need them to be world experts in. So I think Clinica's got that quite nicely set up.
Thank you. Well, on behalf of all of us, thank you, Harry, for a wonderful talk. And thank you all for coming to the inaugural Clinica London Eye Academy meeting. We can mill around for a few minutes now and chat. We've got some cake coming up and I'm sure you've all got more questions to ask Harry. Thank you very much.
Ask questions. Anybody wants to email me in?
Harry, I realise that we've kept you from your family. Now,